lecture is on carcinoma of the esophagus and also strictures of the esophagus, right? Okay. Now, carcinomas of the esophagus are important because malignant tumors of the esophagus are actually commoner than benign tumors, right? And it's one of the commonest gastrointestinal cancers in Sri Lanka, right? In fact, we have about 1,500 cases a year diagnosed, right? It is a disease of the elderly, right? And therefore, these patients often have a lot of comorbidities. It is also more common in males than in females, right? And although surgery is the most trusted form of treatment, have poor survival rates ranging from 5 to 10% if you follow them up for 5 years, right? 5-year survival rates are only about 5 to 10%. So therefore, early diagnosis improves the cure and the chance of survival. And this is basically what we tell you all, right? To pick up these cases early. Now, and refer them. Now, when you look at the types, the histological types, you have squamous cell carcinoma and adenocarcinoma. Squamous cell carcinoma you usually get in the cervical esophagus and in the upper 2/3 of the thoracic esophagus, right? And generally at the lower end of the, in the lower part of, lowermost part of the thoracic esophagus and in the abdominal esophagus, what you usually get is adenocarcinomas. Now, adenocarcinoma is commoner in the Western world and the incidence is rising because of its association with Barrett's esophagus, right? Gastroesophageal reflux disease and Barrett's esophagus. There is also an increase, right, in tumors of the cardia of the stomach, right? And yes, so that is something that you need to know. Now, when you look at the etiology of squamous cell carcinoma, there are certain things which are preventable and certain things which are, of course, not preventable, right? So if you take smoking, betel chewing, alcohol, right? Those are preventable causes of morbidity, right? And then there are other risk factors which are, of course, not preventable. Now, one of them is echalasia, and in the morning we talked about echalasia. Echalasia increases the risk of esophageal carcinoma. Then you have corrosive strictures, right? Strictures due to acids or alkali, right? And those also have a pre-malignant potential. Then, of course, there is this condition called tylosis A, which all the medical students know about, right? I don't know whether it has ever been even reported in Sri Lanka. So in this condition, you get hyperkeratosis of the palms and the soles. And the patients, nearly all of them, right, develop esophageal carcinoma by the age of about 30, right? So that is tylosis A. Now, when you look at the etiology of adenocarcinoma, there's only one factor, and that is Barrett's esophagus, right? So you have gastroesophageal reflux disease, and then once it goes on for some time, you get what is called Barrett's metaplasia. Now, metaplasia means, as I told you in the morning, the word metaplasia means change of one cell type to another. So now, instead of the normal esophageal mucosa, right? What you see is, intestinal metaplasia, intestinal type of mucosa. And that is Barrett's esophagus, right? And this Barrett's esophagus, then in some patients, it becomes dysplastic, right? So you get mild dysplasia, moderate dysplasia, severe dysplasia, and then finally you get carcinoma in situ, where the tumor is confined by the basement membrane, and then when it infiltrates the basement membrane, then it is called an invasive adenocarcinoma. Now, by the time patients present with dysphagia, the disease is often advanced. So like what we said in the morning about carcinoma of the stomach, patients coming with loss of appetite and loss of weight, having advanced malignancies, right? These also can be advanced. So the working diagnosis is if you have dysphagia for solids, which is progressive in the elderly, right? Then that is, then you got to think in terms of carcinoma of the esophagus. And in these patients, initially the dysphagia is for solids, and then gradually they start developing dysphagia for liquids as well. So any adult, right, who say over the age of about 40, right, who is presenting with these symptoms, always think in terms of the possibility of a carcinoma of the esophagus. Loss of weight is also a feature that comes late. Loss of appetite, usually you don't get in squamous cell carcinoma of the esophagus. So in squamous cell carcinoma of the esophagus, appetite is often normal. But when you have adenocarcinomas, you have loss of appetite, and it is believed that this is because in adenocarcinomas, the tumors secrete various metabolites, various substances which act centrally and cause loss of appetite. Then there are other features, right? Nutritional. Now you know that you can get vitamin deficiencies, so you may see things like bursitis and ankylostomatitis and things like that. Okay, so those are the other things to look at. Then there will be features suggestive of spread, right? For example, if the recurrent laryngeal nerve is involved, there will be hoarseness. You can have cervical lymph nodes also being involved, and sometimes there may be abdominal signs like ascites. One of the biggest problems that these patients have is chest aspiration, neural, right? So that is the yes, central nervous system and also the skin. So early disease, if it can be diagnosed, has a better prospect and a chance of a cure. And in the early stages, what patients may have is some sort of non-specific dyspepsia and a sort of a vague feeling in the chest. Right? And of course, if you are screening for Barrett's, right, in these long-standing patients with GORD, right, you're likely to pick up this, right? And also, earlier detection has become possible due to the widespread use of upper GI endoscopy. Now, this is a Barrett's esophagus, right? So you can see here, that's the normal pale pink mucosa, and you have this beefy red kind of mucosa, which indicates a Barrett's esophagus. Now, if you look at diagnosis, right, just like what we said for gastric carcinoma, upper GI endoscopy or esophagogastroduodenoscopy, OGD, and biopsy is the mainstay of treatment. And like I told you in the morning, these tumors can take about 3 different forms. You can get ulcers, you can get polypoidal growths, and you can get strictures. And sometimes it's a combination of these because you will get a ulcerated polypoidal growth, or what is called an ulceroproliferative growth. Right? Now, one thing is that all lesions should be biopsied. You have to be aware of potential lesions, right? Then we have barium swallow and screening. Now, generally upper GI endoscopy is sufficient for diagnosis, but if for some reason endoscopy cannot be done, right, then you can resort to this barium swallow and screening, but generally it is not done nowadays to diagnose carcinoma of the esophagus. But if you do have it, right, you get what is called shouldering and rat tail or apple core appearance. Now, if you look at this, right, this is an endoscopic view of an esophageal carcinoma, right? And you can see this sort of proliferative growth, right, with some degree of ulceration also. Now, this is a barium swallow picture, right? And in the days before endoscopy, this is what we had, right? So here you find, right, now this is the upper esophagus, this is the lower esophagus, and the block is here, right? Now, if you look at this area, sort of if you invert it, right, turn it upside down and look, right, this area looks like a shoulder, right? So that is called shouldering. Then if you look at this, right, if you are a little imaginative, if you look at this part, so this is where the tumor is, right? This is where the tumor is. If you look at this part, you will see that it's an irregular line, right? It's irregular, and there is narrowing, right? So that means there is a uh, so this is what you call a rat's tail appearance. Because if you imagine a little, right, that looks like the back of the rat, right? And then this looks like the tail of the rat. And because the British are fond of comparing this with food items, it is also called an apple co-appearance. Apple co-appearance. Now, how does this tumor spread? Just like what I told you for gastric carcinoma, you have direct spread, you have lymph node spread, and you have hematogenous spread. So direct spread is to the mediastinum. Now, mediastinum is not a good place because it's a very compact thing, right? It's a small area where you have a lot of vital structures running up and down, okay? And things that can get involved, right, due to this spread include the aorta, the trachea in the upper part, the left bronchus, which is a relation of the esophagus, and also the pericardium. And of course, the pericardium gets involved, the heart also can get involved, right? So these are the areas that can get involved, right? This is of course in addition to intercostal nerves and things like that. So, so that is important, right? So then you have, then you also have in esophageal carcinoma, you have what is called submucosal spread. That is just under the mucosa, the tumor can spread up and down, right? And this becomes important in resection because you need a wide margin, right? It is believed that this can spread up and down about 8 centimeters. Okay. Now, with regard to lymph node spread, it spreads to the paraesophageal lymph nodes, then the other mediastinal lymph nodes like the tracheobronchial and bronchopulmonary lymph nodes, and then finally to the through the thoracic duct to the left supraclavicular lymph node. So that is called Virchow's node or Troisius sign, as I told you in the morning. Okay, and mediastinal lymph nodes also will be involved. Okay, when you take hematogenous spread, right? Hematogenous spread will occur to the lungs, it will occur to the liver, and also more rarely to the central nervous system, meaning the brain. Now, when it comes to staging, right? You want to stage the primary and you also want to look for lymph node metastasis, right? And also distant metastasis. So, the staging is usually with CT scan, right? MRI is also not commonly used. The staging modality that is frequently used is a contrast CT scan of the chest and abdomen. So just like for gastric carcinoma, you need to look at both the chest and the abdomen. And when you do that, right, you can see whether it has spread. Having said that, sometimes it is inaccurate. Like I told you in the morning, right, where even after CT scan, you may think it is operable, but it might actually be inoperable and it is better to do a laparoscopy. I told that for gastric carcinoma, right? So here, of course, if it's at the lower end, of course, it will be a laparoscopy. If it's above, then maybe a thoracoscopy, right? But CT MRI still is the main investigation. Then, of course, you have endoscopic ultrasound. If it is available, it's a very good investigation to check the depth of penetration, right? The T stage, how far it has penetrated. Now, remember all these malignancies, right? Whether it is esophageal or gastric or colonic, all the carcinomas, they rise from the mucosa. In fact, a carcinoma is a tumor that rises from the epithelium, right? Okay, from the endoderm, right? So it arises from the mucosa and it goes through the muscle, and you can assess the depth of invasion. You can also look at the paraesophageal lymph nodes. There is a place for bronchoscopy, right? And particularly in tumors of the upper 2/3 of the esophagus, right? If you think that there has been involvement of the trachea or the bronchi. And laparoscopy is, as I said, useful when there is adenocarcinoma of the distal esophagus, right? To assess a spread, right? Just prior to surgery, right? Then, of course, it can extend below the phrenoesophageal ligament. You can get transperitoneal spread, or what we called transcoelomic spread. Same thing, right? In the morning. So that you can have, and it can go to the ovaries, right? Then you can get liver metastasis, right? And you can also get lung metastasis, right? And when it spreads to the paraesophageal lymph nodes, right? And then to the lymph nodes which are further away. So if it's at the lower end of the esophagus, if the tumor is at the lower end of the esophagus, celiac lymph nodes could be involved. Now, the important thing about assessment, spread and staging is that we should try our best to avoid delays, right? So clinically, when you assess these patients, right, there may be wasting, right? There might be dehydration, there may be vitamin D deficiencies, there may be a left supraclavicular lymph node, right? The patient might have a enlarged nodular liver, there might be free fluid, right? Then you may feel lymph node masses in the region of the epigastrium, right? And then, of course, you may have secondaries in the brain, bone, and skin also. And it is also necessary to do a CT MRI of the chest and abdomen. This is, of course, after doing an endoscopy and getting the diagnosis. Ultrasound scan also has some value in the sense you can look for liver metastasis, you can look for ascites, and if lymph nodes are very large, right? Like very large celiac axis lymph nodes, they can be detected on ultrasound, but CT is a better investigation because we want to assess the local spread also, local and regional spread also. Then you have chest X-ray, right? Not very useful, but of course, if you take a chest X-ray and supposing you find, right, secondaries, right, in the lung fields, or if you get a pleural effusion, right, then you would strongly suspect, right, that it is due to the malignancy, and those things will make the patient inoperable, the tumor inoperable, right, or unresectable, because there's no point if it has spread to the lungs and so on. And then, of course, you have And then, of course, as I mentioned, you have endoscopic ultrasound. So you need to assess and optimize the patient. It's very important to as doctors, to get a good systemic review, right? From these patients, very important, right? To do a good systemic review, evaluate for comorbidities, right? And in the elderly patients, especially, you need to do a risk assessment, right, prior to surgery, and you need to inform the patient about the risk, right? And especially, you have to pay attention to the to the cardiovascular system and the respiratory system if you're planning to do surgery, right? And in these patients, it's almost mandatory to do the lung function test. Now, generally for abdominal surgeries, right, most of the time, we don't do lung function test, but you know that the esophagus, right, is in the part of it is in the neck, part of it in the chest, and part of it is in the abdomen, right? So you need to do the lung function test and arrange for pre-operative chest physiotherapy, right? Okay. So, and then of course, you have to assess fitness for major surgery and anesthesia. Actually, this is not major, this is beyond major. This is what you call a major complex operation, right? Because it involves surgery in 2 or 3 body cavities, right? Sometimes it's all 3, abdomen, chest, and neck. It's also very important to assess the patient's nutrition preoperatively, and a lot of these patients have nutritional problems, and now we are privileged actually to have nutritionists who look after these patients, and they need to be supported, right? Preoperatively, you have to feed the patient to improve the patient's nutrition prior to surgery. So if the patient can take liquids, then you can give a high protein liquid diet, right? But if the patient cannot take liquids, in other words, if the patient has dysphagia for liquids, then there are several options. I mean, you can put an nasogastric tube or an nasojejunal tube and feed through that, right? Or in some instances, even if that is also not possible, right, you may have to consider doing a feeding jejunostomy, right, where you put a Foley catheter into the jejunum and then you feed the patient through that. Right? we avoid gastrostomies, right? Don't do the other option, of course, is total parenteral nutrition, right? You can go with total parenteral nutrition also. This is to feed the patient up, right? To build up the patient's nutrition for a couple of weeks prior to surgery, because a lot of patients require that. Now, gastrostomy is not done. You might wonder, why can't we put a tube into the stomach? Because the stomach is used during this operation, right, as a conduit, right, to bring up sometimes into the neck, right, to anastomose, sometimes in the chest. So therefore, we don't do that, right? You need to have a good albumin level, right? Now, we must optimize the patient nutritionally, but at the same time, you can't wait for too long also, right? Because the tumor might spread, right? So for a couple of weeks, right, you can optimize the patient and then plan your treatment. And if there is obstructing food material, of course, that has to be cleared. Now, the treatment for this, right, the potentially curative treatment, I told you there's no guarantee of a cure here. Potentially curative treatment is esophagectomy, right? And you need to take the appropriate length of the esophagus. I told you there can be submucous spread up to about 8 centimeters. And you need to remove any involved stomach. Now, sometimes these tumors, right, at the GOJ have spread, right, to involve the fundus of the stomach or part of the fundus near the cardia. So that part has to be removed with a clear margin, right? And of course, you need to remove the locoregional lymphatics as well, right? Then, of course, there is, and you have to also take into account the fact that there is submucosal spread, right? So there are various ways of resecting the esophagus. You don't need to know the details, right? So there was this person called Ivor Lewis. What he did was, he did a right thoracotomy and a right lateral thoracotomy and a left and an abdominal incision, right? And then through that, he resected, the part of the esophagus and part of the stomach, right? And then anastomosed the stomach to the esophagus. Okay, so that is called the Ivor Lewis operation. Then you have this McEwen's operation, where you actually operate in all 3 body cavities, right? So you mobilize the abdominal esophagus, the thoracic esophagus, and then the esophagus in the neck, right? And then you remove a lot of esophagus, and then you bring the stomach up. You roll the stomach up like a tube, and then bring it up to the neck and anastomose. These procedures can also be done thoracoscopically. The chest part can be done thoracoscopically, and the abdominal part can be done laparoscopically nowadays, right? And then, of course, there was this person called Oringer, who described what is called Oringer's esophagectomy, so or transhiatal esophagectomy. So in this operation, the advantage is that the chest is not open, right? And you use finger dissection to separate the esophagus, right, and the tumor from the other tissues. The problems are sometimes you can get damage, right, to structures because you can't see, and you can get massive bleeding. The other thing is sometimes the tumor clearance is not very good, right, when you mobilize blindly with the fingers, right? What about post-operative care? Now, initially, these patients, most of the time, go into an intensive care unit. The operations are long, right? It involves 3 body cavities, and one of those body cavities is the chest, right? So the lung, takes a hit, right? So therefore, most of these patients are then transferred to the ICU, right? And then they have all these tubes, cannulae, right? Drains and things like that, right? Coming out of them, right? And then you have the, you provide the fluid and the nutrition, right? And, right? And then, of course, that's what you do. I mean, sometimes during the surgery, we do what is called a pyloromyotomy. That is because now in this operation, both vagus nerves are cut. So when the vagus nerves are cut, you get reduced gastric emptying, right? So for that reason, we divide, because the vagus nerves are divided, right? You do a pyloromyotomy to correct that. Then, of course, you'll need to give analgesics and antibiotics. You'll have to refer to the physicians and the, right? And so on, right? Okay. So you need analgesia and antibiotics, right? And some of these patients have reflux because post-surgically, because if you think about it, right, now everybody has a upper esophageal sphincter and a lower esophageal sphincter. Now in this operation, the lower esophageal sphincter always gets removed, right? So when it always gets removed, right, then you have only the upper esophageal sphincter. So therefore, the sometimes bile or the fluid in the stomach will reflux into the esophagus, definitely, and then some of it may reflux more, right? And you might even have things like aspiration pneumonias and so on, right? And you need to introduce the oral intake fairly early, right? And one of the dreaded surgical complications you can get after esophagectomy is a leak from the anastomosis. Okay? So then there is also adjuvant treatment or palliative treatment. Now, in squamous cell carcinoma, there are studies which show, now we were talking about surgery, but in squamous cell carcinoma, there are studies which show that the results are comparable, that is surgery versus radiotherapy and chemotherapy. And they use a drug called cisplatinum, cisplat, along with the radiotherapy, right? And that also gives acceptable results. So you can judge depending on the fitness of the patient and all, whether you are going to the radiotherapy or whether you're planning to do surgery, right? But probably with surgery, survival is longer, right? But mortality also is a little higher. Then you have chemotherapy, and like I said, the oncological care of these patients has improved with cisplatinum, right? But you see, it doesn't cure the patient, right? But it keeps things under control for some time, right? Now, sometimes we are faced with this question of whether we are going to resect or whether we are going to palliate, right? So there is this operability. Now, in other words, if the patient is unfit to undergo a major surgical operation, then you have to think about palliation, right? And if you're optimizing, then nutrition, lung function, cardiac function, all these things become important, right? Now, when it comes to advanced carcinomas, right, then palliation is the only option, right? So cure is not possible, but at the same time, you don't unnecessarily try to prolong the patient's life if the quality of life is very poor, right? Because the survival is expected to be quite short. So what do we do in these patients? Now, their main problem is dysphagia, right? And gastrostomy is not a good option, right? So what we do is, right, you can stent the esophagus, and that is the most commonest form of palliation now, right? Endoscopic stenting. Earlier, people tried laser, right? You can, right, to burn the tumor, ethanol injections, and so on. There's a limited place for dilatation because if you can't put the stent, right, without dilating, then you dilate and put a stent, right? And these are, of course, some of the older stents, right? Celeste. But now today, what we have is what is called a SEMS, right? What is called a SEMS. So these are the olden day stents, right, which were developed about 100 years ago, right? But now here, what we have, right? Now this is a carcinoma of the esophagus, right? I showed this picture earlier also, right? And this is the palliation for it, right? So this is what you call a self-expandable metal stent, right? It is compressed like a parachute and put in, right? And then you release it, right? And it becomes like this, and it keeps the lumen patent, right? Just a minute. Hello. Oh. 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 Department. Department. Okay, department. Surgery department. Surgery department. Hi. And කවදද PVC එක? ඉස්ති අතර කියන්නේ මේ සෙනසුරාදානේ. මේ සෙනසුරාදා උදේ අපිට. හරි. Okay. Thank you. කොහෙද? කොතනද? ඕඩු ප්‍රී එකනේ පාරණ බිල්ඩින් එකනේ. පාරණ බිල්ඩින්. හරි. Okay. Thank you. Right. So, so this is a self-expandable metal stent, right? Now, moving on to strictures, right? Strictures can be benign or malignant. And causes of strictures include corrosives, that is acids and alkali. I think in the medical legal module, you have a lecture on corrosive poisoning, right? And then gastroesophageal reflux disease, right? Where again you're getting reflux of acid, right? And over a long period of time, it can cause a benign stricture. Then radiotherapy, if it is given for another tumor, say for example, a lung tumor, something like that, it can cause strictures. And then after surgery, right? After surgery, after esophagectomy, there can be what you call an anastomotic stricture. That is a stricture at the anastomotic site. Right? And generally, strictures are treated by dilatation, right? You can treat it by dilatation, and that is dilatation, right? Because what you do is you have this endoscope, and through the endoscope you pass this balloon, right? And the balloon is fitted onto the balloon is actually connected to a channel, and through that you inject water, right? And you dilate the stricture, right? Okay, so and if this treatment doesn't work, supposing there are multiple strictures, right? Or if the strictures are very tough, difficult to dilate and so on, then those patients will need surgery. And the surgery is very similar to the surgery that I told you for malignancy, except that you don't have to worry about lymph nodes and things like that. Okay, right. Okay, thank you then. And any questions? So this is just an outline, right? And you will learn a lot about this condition as you go along, right? In your clinicals, you will come across patients and whom you will be able to discuss, right? But I believe all the important things I have mentioned. Any questions? Okay, so 74. Right. Okay, thank you. Thank you very much.
Thank you, sir.